I'm so happy to welcome Professor Gangadhar. He's going to speak about redeeming the spirit of medicine, improving patient outcomes by creating a joyful workforce. In the evolving landscape of healthcare, patient outcomes are no longer driven by clinical excellence alone. The well being, motivation, and emotional resilience of healthcare workers are equally critical. Let's learn from him what he has to say about this.
I don't want to come in between a delicious lunch of this conference and you. I would try to be as brief and as focused as it can be. We are, of course, discussing a very practical but yet very difficult subject of how to find a purpose which will end up in a joyful outcome in medical profession and as a profession of a medical teacher as well. Seeing the logo here of the CAHO, care and make it safe, reminds me of a anecdote. People who have heard me earlier would have perhaps listened to this anecdote from me on the talk, but that perhaps summarizes what the small font part of the logo which is there on the screen. Care and ensure that it is safe. It seems all of you, of course, have heard Mahabharata was written by Ganesha on a condition that the person who is dictating him, the Vyasa, will dictate it without any break, and Vyasa has to connect the strings of the entire Mahabharata episode. Whenever he forgets a string, instead of stopping, he has to make sure that this person continues to write, because otherwise he would run away and he would start telling some other trailer stories, and then the main story will continue. It goes on. A longest movie with the highest number of trailers is what is Mahabharata. All of you have heard, of course. The Upakathas will go on. In fact, the Upakathas are more than the Katha there. Nonetheless, at the end of all writing, when the last words is said, Ganesha by then is exasperated. He can't express his anger because person who is dictating was Vedavyasa himself. He still expresses his discontent. You made me write so much. I think you have tortured me, and so on. Then the Vyasa says, look, I have become old. I have been writing all my life, and I have written so many things. So I got tired. So I asked your help. So please don't mistake me. This is what I've been doing all my life. Ganesha is very amused. What did you write? You would never have written so much what I wrote now. So he takes him to his library and shows him all what he has written, the Vedas, the Vedangas, the Upanishads, the Puranas, and so on and so forth. He says crores and crores of verses have been written, and Mahabharata in that sense has been a smaller version of what all I have written here. So Ganesha gets amused and says, why did you write all these things? No, I wrote these things so that by reading these things, people will become very good. Bad people will become good, and the good people will become better, and the better people will become the best. So only to teach how to be good, I have written all these things. So Ganesha says, to become good, if I have to read so many books, be assured nobody would be wanting to become good, and nobody would have time to read all these things. You have to give an executive summary in a court judgment. There are pages and pages of discussions go on, and an executive summary is whether I have been relieved from the jail or not. So be a focused executive summary of these things. Crores and crores of shlokas you have written, be an executive. So then he says, why in one shloka I will tell in half a shloka what is the summary of all I have written. Shlokardhena pravakshyami yaduktam grantha kotibihi. In half the shloka I will tell you what I have written in all the crores and crores of these verses. Paropakara punyaya papaya paripidanam. Being good to others, being useful to others is what is punya. Sorry, there is no good English translation for this word punya though. Papaya paripidanam. I am sure you know that. Whatever that is done bad to others would give you that sin. In fact, you go to any culture, any philosophy, whichever is part of the world, and this is the essence of what we have to lead our life as. And this precisely tells me care, paropakara, papaya, being unsafe is papa. So in the process of doing good, we also have to keep reminding ourselves that we ought not to be doing anything bad, even unintentionally. And that's where we learn from people who keep sensitizing, bringing this awareness on standards. And so I thought in this conference, this verse would probably take home an important message at the end of our talk today. Coming back to the spirit of serving, spirit of this purpose of medical service, medical education for that matter, being in the thick of the medical education, I have always felt that there are three important pillars in the success of medical education. They keep telling that you have to provide quality education, and this word quality education has become now even more important now that the quantity is increasing. So everybody has to oppose the quantity, divert our mind away from quantity, and to make sure that we remain focused only on quality. And so time and again, wherever I have gone, wherever I have spoken, people tell me that you have to ensure that the quality education should happen. When it comes to quality, I am reminded of a couple of anecdotes in my own life, but more importantly, a recent anecdote that I have had. I've been interacting, of course, in the last 40 years of my service as a doctor, teacher, and various administrative roles I have been doing. I've been interacting with a lot of people, a lot of doctors. Each time I meet a set of doctors and I come back, I feel very proud. I feel a sense of goodness that I have been with such excellent people in their profession. I want to repeat this because I have seen, at least in my coming across in the 40 years, doctors, I have seen people who have been so dedicated, so motivated, and so good in their medical skills and profession. And to be said that I should further improve this quality, sometimes I feel we are perhaps belittling our own medical profession. Medical profession in our country perhaps is one of the very good. I have to give you one anecdote just to, I'm sure you would probably recall hundreds of such anecdotes. A cardiology friend of us, a common friend, my friend was a very senior orthopedic doctor. We were having some discussion and we were having, I think, we were together on a dinner table late in the evening at about 9 o'clock or 9:30. This common friend who is a cardiologist had a neck of the femur fracture in one of the countries abroad, very developed country. I don't want to name the country though. And he was calling him, look, I have been scheduled for a surgery. Would you like to have a word with the surgeon who is going to be operating me? So this is a senior cardiologist asking his friend in India, a classmate, who is a orthopedic surgeon, about the surgery to be done there in that country. So he says, I'll be happy to talk to your surgeon, orthopedic surgeon, because we are could be in the same wavelength. We will discuss this and let you know. I am sure you should be reassured. So they talk for some time, etc., and he talks to this cardiologist. Everything is over. It's about 20 minutes of conversation that goes on, during which time I'm sitting with other people chatting, but I'm observing what is happening. At the end of the talk, he tells me, he was concerned. He wanted to inquire whether the surgery was fine, okay, best surgery, etc. This prosthesis they're going to be using is a good thing, etc. At the end of it, he told me that this country, which is selling these products to us as well, we are importing from them, this person is doing a surgery which is about 15 years old surgery, whereas today many of our orthopedic surgeons are doing a even more modern surgery in our country. So which made me feel very, very good in the sense that we are perhaps up to date. At the same time, just about 3-4 days back, when I was in the National Medical Commission, I got a phone call from a lady doctor who is a senior, who is a consultant, or who is actually a faculty in a medical college. I don't want to name the medical college nor this person. Wanting to go to some other country and wants a good standing certificate. He says, sir, in 3-4 days I have to leave unless I get it good standing. I keep getting these calls at very odd hours, and this was almost at about 11 o'clock in the night, and this girl had called me and saying that I want this certificate. Anyway, certificate was organized, given, etc. But I was talking to her, why was this hurry to get this certificate? Where are you going? Some country X. Okay, again, I don't want to name the country, a country which is perhaps not as big as even Delhi city itself. So that's the country she is going, and she wants the certificate. Perfectly all right. What are you going to do there? Yes, I'm going to work in a hospital under so and so. Under so and so means what? You're already a consultant, you are already a faculty. What do you mean working under? Then she said, no. Once we go there, unless we work for 3 years under a senior person, we won't get an independent registration. To be independent consultants, I have to be working under somebody. This left a very, very emotional mark in my mind. And the last 4 or 5 nights, whenever I went to bed, this conversation keeps haunting me. In a country which few months back, I heard that my friend saying that we are doing the most modern surgery, vis-a-vis that very developed country which is still doing 10 to 20 years old surgery for these people. As against that, people who are getting graduated there, the world vision is perhaps different. They view that we, in spite of being postgraduates, in spite of being teachers to postgraduates, I am going there, they will still feel that they have to see my work for the next 3 years before I be declared as fit to be practicing in that country, and not as big as even Delhi. This made a very emotional impact on me. And while I am seeing the best doctors around me, and I know they are the best people, and I have myself had personal experience of being exposed to them and, of course, interacting with them. But whereas the world view has been different, where is our goal to be? The goal to be is that we get out the best medical doctors. Indian medical graduate should be the prototype example as the best medical doctor in the world. Can we achieve this? This is a thought that has been going on for the last 4 or 5 days. It's just coincidental that I've been called to talk in this thing. I cannot forget this episode of conversing with this lady who is a senior PG with a gold medal and then goes on to work under somebody. Leave all these issues apart. The point I'm trying to make is how we finally achieve that best medical education and the quality medical education, which is what has been one of the objectives, the only objective, the main objective of the National Medical Commission ever since it came into picture. And I have seen people like Dr. Sharma, who was the earlier chairman, and now, of course, Dr. Achal, who has been with me even before I went into National Medical Commission. Achal Gulati was known to me in the National Medical Commission. I have seen that spirit of how to get the best out of this medical student as a doctor, and the best doctor, the best specialist, and of course the best teacher or a best consultant or whatever you want to call it. If that best has to come out, what is the ingredient that should go in? What is the ingredient that finally results in that best output as the doctor? To be fair, I'm not asking a big list of things to come in to make that end product that is the best medical doctor in the world. There are three ingredients which I think are irrefutable. There is no compromise. And if these three things happen, the outcome is the best. One of them is, although I'm not going to put them in that order, but the three things, the three pillars of the best and the quality medical education would be a very happy student. Number two, a satisfied patient. And number three is a motivated and dedicated teacher. These three things are there, the best outcome in the medical student or a PG will happen. You may not have the best medical equipment. You may not have an overcrowding outpatient. You may not have a highly paying PG job. You may not have the what is called as a very posh classrooms, air-conditioned office rooms, air-conditioned library, and internet that will get you any information on your palm top. You may not have all these things, but if these three things are not there, a happy resident, a happy medical student, a satisfied patient in good numbers, and of course, the motivated and the dedicated teacher. This last part actually is the central thing. A happy student is a result of a dedicated teacher. As long as the teacher is dedicated to teaching and service, a student cannot be happy. Again, a satisfied patient comes as a result of this teacher who is also a clinician, who is also a person who is helping him with the laboratory reports and so on and so forth. So the central person is this dedicated teacher. All of us have that part of our medical profession in ourselves. Not just being good clinicians, I'm sure formally or informally, we have all operated as in the role of being a teacher. Some way or other, to a junior consultant, to a nurse, to a PG who is getting posted under us, or a person who is doing his thesis, or a medical student in our classroom where we have taken a class, demonstrated some experiments to him, etc., etc. So this part of it perhaps is the central thing that is going to bring out the best doctor, not only in the skill, but also in terms of that spirit of having to serve the same way that this medical teacher has been serving the other person. And this senior consultant, the way he is functioning, that I am also going to function the same way. So this essential principle of being a happy, skilled doctor, to be useful to the patient, making the most satisfied patient, is the purpose of my education. And this comes by way of my paralleling, mirroring that most dedicated and motivated teacher. So these three ingredients are centrally important. We have recognized it time and again. And in fact, the stress to a medical doctor who is pursuing, or even a medical student who is pursuing the education, has figured very important to us. And we in the National Medical Commission have debated how to reduce the stress levels and how to work towards well-being of the medical student or a PG There are several things that we have introduced. I don't want to boast by giving a list of things that we have done, but a few things I just have to mention. Anti-ragging regulations, ensuring that the PG student gets the best in terms of prescribing some minimum conditions for a good working. In fact, the PGMER also mentions that there should be some, I wouldn't say fixed number of hours, but should be a considerable amount of overworking should be avoided. Like the point was said, maternity leave, because by the time we come into PG, very often the students would be expecting mothers, and it's fair that they are stress-free both for the child and for their education. So this was also facilitated. And we, of course, went into the suicide attempts which have come up, and we have made a something like a grievance committee. I don't want to use the word grievance committee. Any related events are being examined in the college. By asking the college to come and give an information. We have also made a survey of what is the stress levels the junior consultants, the teachers, the medical students, and the PGs are experiencing, and how we have a list of concerns that we have to address. That also we have prepared, and in fact the number of recommendations to mitigate those concerns have been again very extensive. Those have been recommended. This entire book volume is available on the website of the National Medical Commission. And lastly, of course, many teachers may be angry on that issue, that at the end of 3 years, a person has to give his thesis. Until the thesis is approved by the guide and the college, he or she couldn't write the examination. This condition, again, we have made it different. You should do the thesis with that interest, wanting to have a research coming out of your work. Need not necessarily be controlled for whatever may be the reason by the teacher. You write, submit the thesis. Thesis will have a mark. And the examiner, who could well be your guide, who could well be your dean, could give you 0 mark, but other examiners could give you a different mark. It does not mean that this person is giving 0 and you are fully not eligible to even appear for the examination. This concern also was observed. So the PG board took a decision that he has to submit the thesis like any other answer paper he submits at the end of the examination, and complete the examination processes. Thesis is a part of rest of the evaluation that happens to this individual, and not the only issue on which he will be barred or debarred from taking the examination. So these issues have been brought out to make sure that the course of one's work in the hospital is as smooth, as joyful, as pleasant as it should have happened to the individual. At the same time, we of course keep seeing that there are overworked residents, a lot of clinical work that they have to do, a lot of expectations from the seniors, and the same unit is handled just by 2-3 consultants, whereas the 1 or 2 residents working under them have to do the entire work. So these are all concerns that have cropped up, and more importantly also the safety concerns of the doctors who are working there. These are all issues which have now come up in light, and the national task force in which I have had the good opportunity to work and put up some recommendations to the Honorable Supreme Court, which now we are also trying to bring them into a part of the condition of working in a medical college, hospital, and so on and so forth. All these things, mind you, most medical colleges have already practicing many of these things by letter and spirit, writing it to them. There could be some situations where something has been missed out, something has not happened, and so a trouble starts. So to make sure that these things don't happen also, more and more safety measures as a precaution have been talked about, and this is precisely what the standards groups of people, whether NABH or whatever it is, they keep telling us, you do all these things, you are likely to mitigate a complication having to occur. And this is precisely what we also believe in the National Medical Commission. when it comes to education that goes on. You follow all these things, it is least likely that the student will experience any discomfort, and he is continuing to be there without any burnout and complete his education with most satisfaction and with best result. So having said all these things, I probably will conclude now with a small observation about what a senior can teach a junior. I am reminded of this anecdote happened in 78. One very senior director of an institute whose driver lived in the same campus, but whereas the director lived about 6-8 kilometers away, and he used to bring him home and drop him home and bring him to the work and drop him. This driver was doing this work, and one day the director found that this man honked more while he was driving him from home to the hospital into his office. And he also found that when he parked the vehicle, more often than not, he would be so brisk to come and open the door for the director. This time it took some time. Very spontaneously, the director also had gotten out by then. By the time he came there, it would not happen. And then he would walk the director till the room, his office room. Although he wouldn't carry the bag, the director did not allow him to carry the bag. He, by nature, was a different person. So he carried the bag, but he didn't accompany him till the gate. After the director got down, the person went into the car and went down, drove the car back. In the daytime also, in the work, he did not see him while taking him to the wards or while taking him to the outpatient, as a different person. And after about 11:30, 12 o'clock, this person was different, was more joyful, was more efficient. He was like the original person. During the lunch hour, when he was about to be going home for lunch, that who was a very astute observer of this behavior in his junior most colleague, asked him, "Look, this is the thing I have observed. What happened?" Something was different in the morning, and afternoon, post coffee break, sometime around that time, you were a different person. Then he told what happened. His daughter was expecting, and she was at home. And when he was about to start the car to come to pick up the director in his house, the daughter developed the delivery pains, and at home, his wife and a younger son, the only two people were there. But this man said, "My duty has to bring the director to the office." So he told the son to take the sister, to the hospital in an auto and make sure that it is followed up there. Mind you, in 1978, no cell phones. His home did not have a phone. The son did not have a scooter to bring and message whether the person delivered or not. They went to the hospital. Delivery happened. The hospital where delivery happened, the ambulance driver happens to know him. He came on his own two-wheeler and told him that your daughter delivered or whatever, blah, blah. After that, his demeanor changed. He narrated the whole thing to the director. He told me, "I felt so moved by this person's behavior. When the daughter had delivery pains, he could have taken the same car and could have come half an hour late. I wouldn't have perhaps mattered. But still, this man's dedication is something that was very appreciative." But in the narration, what I observed was that director's astuteness to observe all these changes in his junior. So, dedication in this person perhaps might have come by that senior being so concerned about the junior. All these things made me change, made me learn a lot of lessons over a period of time. Bringing back to the first shloka which I said, "Paropakara punyaya papaya paripidanam." All through my time, can I always be thinking of being helpful to others and making sure that no one else is pained. And if that principle, if I have been following, perhaps I would probably succeed. I don't know whether I have followed or not. That's a different issue altogether. But the point is that one formula in our life in a medical education as well, and becoming a doctor perhaps will bring out the best experiences to that medical education process and being continuing to be as a medical professional over the time. Towards the end, another anecdote of an examination, which I have to say, we always keep saying that we're all overworked, a lot of clinical load, and so on and so forth. There was an examination which went on. The logbooks of these students were being examined to give gold medal to a person X. Looking at the logbook, and in the logbook, person X had done almost 4-5 folds more surgeries than the other 6 other classmates of him. And the experts thought that this man fraudulently has written more surgeries in his logbook. So he was called again and was asked to explain, how is it that you have done almost 5-6 times more surgeries than your colleagues? So this chap said, look, I was in the hostel. When I was doing duties, I used to find, I wish I had one more person to help me, because there were some surgeries that had to be done, a burial had to be done, decompression has to happen, and suddenly some complication happened in the ward and I have to take the patient again to a surgery theatre. All these things were happening. So whenever my classmates were doing duties, and if I was free in the night, I would come and tell them that I am available. If there is any SOS, you take my help. And so they would let me go to do the emergency surgeries, etc., etc. In the process, I ended up doing more surgeries. It is not because it's just that I was given more surgeries. The hospital did not make me do overwork, nor would I have written anything erroneously. This all happened spontaneously. Just because I felt for my classmates, I thought I should try to be of help to them. I used to come there. I just chance that I have operated more than other people. So this anecdote, which my senior colleague told me that he found it in one of the examination days when he had gone as an examiner, again made me feel that this concept of overwork seems to be so relative, and the purpose this man had to be helpful to his own classmates, his own colleagues, made him the gold medalist, in spite of the fact that he did more work in the hospital, in the ward. So essentially, we keep our purpose in our mind, and the processes, again, being paropakaraya, and making sure that we practice all the safety procedures very spontaneously, not necessarily to have another separate department for ensuring quality and safety. Quality and safety should go along with our work. Being perfect in our work is what is called as yoga in the Mahabharata, in the Bhagavad Gita. Yoga karmasu kaushalam. To the best output, the safest output is the natural thing that we should be doing it, rather than having to be dictated that you should follow these standards. Nonetheless, keep reminding us standards groups are required, but I think that should become ingrained into our professional work. With these few words, perhaps I will stop here. I thank the organizers for letting me come here and share some of my sentiments and observations on this matter. Wish you all the best. Thank you very much.
You know, Professor Gangadhar, he is a great, you are a great chef, great cook, I tell you, because the types of ingredients he has brought out, the type of ingredients in medical training he brought out, all of them are meticulously when used. The dish which comes out will definitely take care of the, safer health care to everybody, including me. Thank you, sir. Thank you very much.
Thank you so much. It was a very engaging talk, sir. And we have to move on to our next sessions. We are a little short of time. The next session is by Kalyan Sivasailam. He's the founder at 5C Network. And by and large, I think most of the conferences, I see him around engaging with people, telling about his venture. And I had an experience to meet him for the first time. When he met me was 6-7 years back, I think. When
6 years
6
back.
years back. And he had just introduced this concept of teleradiology and reporting. and I was very skeptical about it. But when he explained and when we actually implemented it, it is a really very useful tool. And now that artificial intelligence is revolutionizing radiology by enhancing accuracy, efficiency, and diagnostic confidence, they can rapidly analyze medical images, detect patterns, and highlight anomalies that may be missed by the human eye. Let us hear from him what he's doing further to reduce the turnaround time and prioritizing critical cases. Let's hear from him.
Good afternoon, everybody. My name is Kalyan, and I run a company called 5C based in Bangalore. Proud to say that many of the hospitals that keep showing up, including Sehgal sir on the stage, are delighted customers of 5C. I wanted to talk about, I know that there are a bunch of hospital administrators here, and I wanted to actually talk about what AI has done, not for radiology, but what AI has done for radiology in the context of hospital administration. And as any decent speaker would do, I want to cut right to the chase. And I want to tell you, the first thing that AI in radiology has done for radiology from the perspective of hospital administrators. And that is that radiology has gone from a service or from a commodity into actually a strategy that all of you need to utilize in order to make your hospitals better, more efficient, better performing, etc. And that's actually the punchline that I want to leave you all with. That today with AI, radiology is not just a commodity, not just a service. Radiology is actually a strategy. And I'm going to give you 3 examples and then share one problem at the end of this, and we can take it from there. A brief credentials about 5C. We are leaders in multimodal AI applied to medical imaging. Today, we read approximately 1.5% to 2% of all the scans that happen in the country. So that is a lot of data. 5 of the top 10 largest hospitals in the country are also my customers. And like I said, I'm going to talk about 3 things that have changed, that AI has changed in radiology that I really want you to know. And the first one is that radiology today is not in a siloed department. Radiology is actually on the CFO's table. And I'm going to give you an example. One of the largest hospitals in the country, who is also a 5C customer, uses AI to not only understand, not only triage between normal or abnormal cases, but then further utilizes that immediately to triage abnormal cases as either surgical and emergency. We were able to cut down their general overall TAT, even for surgical cases, from 24 hours to 39 minutes. 24 hours to 39 minutes. This absolutely ensured that any case that needed surgical intervention or emergency intervention was taken up immediately. This dashboard that we have built for them is now seen by the operations head and by the CFO of this hospital on a daily basis. So radiology for this customer is not just a department. It is a source of information, a source of intelligence for them to make better decisions and for revenue improvement. Another good example, a customer of 5C is the government of Karnataka. We work very closely with them across many district hospitals and medical colleges for AI-based reporting. There is a dashboard that we have built for the medical education minister, who looks at it once a week, and he's a doctor himself, just to understand what is the disease burden across each of the districts and what are the tools that he needs to equip his medical colleges with to ensure that treatments are better. So again, radiology is not a department anymore. Radiology is sitting at the operations leadership and at the CFO's table. The second is that AI has ensured that radiologists are not just delivering outputs, but they're actually able to ensure outcomes. Many hospital leaders here will be thinking that radiology in many cases fails them because reports are not as actionable as they need to be. With AI, and we have seen this live, that today radiologists can not just focus on just giving outputs in terms of number of reports that they're able to do in a day, they can actually focus on the outcomes that they want to ensure. A very good, example of this would be, again, if there is a case that, for example, needs a surgery, AI can not only flag that as a surgery case, but also based on the follow-up X-ray, help understand when the next X-ray needs to be taken, what the duration of that follow-up should be, and even identify next steps. These are screenshots of not just, of course, name changed, but these are screenshots of live products that are being utilized thousands of times on a daily basis. And so today, radiology departments don't need to just focus on what the output of the report is, but what the outcomes they can drive are. And finally, something that I am very deeply passionate about is that imaging is the new biomarker. I personally believe that the most underutilized and underrated medical equipment in the world is actually the MRI machine. And I'm sure if I take a poll around the number of people who are using an MRI machine and let's say doing a Dixon or an ideal sequence to understand brown adipose tissue versus white adipose tissue, I'm sure there will not be many of you guys here, even though most MRIs today are capable. And imaging is actually the new biomarker. Along with Dr. Alexander Thomas, I was speaking at the Longevity India conference recently, where 5C actually runs a full body MRI protocol to actually help doctors understand their patient's longevity cycle a lot better. There are many other use cases of imaging as the new biomarker. Today, with a very large hospital in Kerala, we're already running imaging biomarker trials for predicting neurodegenerative diseases like Alzheimer's and Parkinson's. We are working with a leading hospital in Bangalore on a research around using fat infiltration in the liver as a biomarker for longevity. So imaging is not just reactive anymore. Imaging can genuinely be proactive. And AI has played a huge role. So let me go back to what I just said. I said that today, radiology is not just a department, it's sitting on the CFO's table. Radiology can now help you deliver outcomes and is not just a place of outputs. And AI is today helping imaging transform from just being a reactive product to being something truly, truly proactive. But in spite of all this, most hospitals still think about radiology as a commodity and not a strategy. A really good example is, we've spoken in depth about wo panch din, NABH, etc. But again, if I take a poll of NABH accredited hospitals, which will be all of you in this room today, and I ask you how many of you report all your X-rays, I am pretty sure, in an honest room like this one, I'm pretty sure I will not get many hands up. Many of the largest customers we work with are not able to get all their X-rays reported, even though AI is live, is available, and is making radiology labor pretty much infinite. And that's the problem that I wanted to share with all of you, which is that where AI is getting today is very, very far from where the rubber is actually hitting the road in the hospitals. And that is what I want to leave you guys with and tell you that AI has really transformed radiology and imaging in a way that is genuinely unimaginable even 3 years back. Today, we have an opportunity to do all these amazing things, which is bring in radiology to the core of your operations, deliver outcomes using AI, not just outputs, and actually doing proactive AI-based imaging rather than reactive. But can we start with getting all our X-rays reported? I think that would be a very good start. And AI can really help with this. If all of you have not seen the 5C stall yet, we are at stall number 20. And my team and I would be delighted to welcome you over coffee and have a talk about how radiology should not be a department in your hospital, but actually a strategy. I hope I made this worth your time. Thank you all.
Thank you so much for finishing in time. I think it saves us a lot of problems. One thing I want to know from you, Siva, all the reports that you are sending to all your centers, how much of feedback do you really get and you take if there is any erroneous reporting? And what are the corrective methods? Because ultimately, all those reports are not only reported by AI,
Correct.
They are reported by some radiologists also,
Absolutely.
where the caliber may differ.
Correct.
Second point is, all those reports which are basically reported by AI, what is the mechanism of finding out is that actually right, or is there error in that also?
So two questions, sir. One is the fundamental question around quality control, at our scale. Today we're doing 8,000, 9,000 reports every day. And quality control is basically at the center of everything that we're trying to do. We have a very large quality control and continuous improvement department of two sides. So we have a human side and an algorithmic side. We try to make it as easy as possible for our customers to give us feedback on the reports. They can do it on call, they can do it on WhatsApp, they can do it even with a single click of a button on our platform. And when we realize that there is a discrepancy between the final outcome, and I will not pretend here that we have never made a mistake. Hospitals make mistakes, healthcare is fraught with it, but it is our responsibility to be as responsible with those mistakes as possible and to minimize them as much as possible. And so when we find a discrepancy, there are usually two loops that we run. We run a human loop and an AI loop. The AI loop is actually a lot easier, sir. We understand whether if the AI has made a mistake, we have to retrain it specifically on that type of mistake that it has made. So for example, if it has misclassified an NG tube in, let's say, an ICU chest X-ray, we have to ensure that the AI that is deployed there is correctly identifying NG tubes. On the human side, it's a little more complicated because humans are more complicated. And so we have to first give this feedback, communicate it with the radiologist who made this error in a professional and not in a punishing manner. And then also at the same time, we track errors by person, by modality, and by pathology. So if a radiologist misses an appendicitis once, it's a problem. But if they miss it twice, if they miss an appendicitis on a CT abdomen twice, that means they're not focusing. That time they go into a separate loop. The second question that you asked is around quality control on AI, right? I think that was your question, sir. Quality control on AI. For AI quality control, I think the fundamental answer to AI quality control is as much oversight as possible. And so we ensure that we're always giving the AI to a human at the moment to ensure that we are delivering output. And each customer can kind of customize their output, sir. So usually there's a threshold of 0.5, 50%, where we predict something. But you always want to make the AI predict more and the radiologist to validate the prediction rather than, tell a radiologist that something is not there when it is actually there. So we will make our models more sensitive, less precise, because we know that there is human oversight. I hope that answers your questions.
Yeah, thank you so much. Basically, that means the future of radio imaging lies in the collaborative synergy between human expertise and machine intelligence. And
100%,
that's what
sir.
we are aiming for and hoping for good.
100%.
Now, going on to next session, we'll try to keep it short by reducing 2 minutes for each one of them if they can manage. Let me invite Dr. ManoDeep Sen. Dr. ManoDeep Sen is the professor of Department of Microbiology, Dr. RML Institute of Medical Sciences, Lucknow. And he has a lot of academic contributions and a lot of workshops and research activities which he has been conducting over a period of time. So he is going to speak on standards in hand hygiene, the right hand rub. Thank you so much.
So a very good afternoon to respected speakers, chairpersons and our audience. So I'll be talking about the standards in hand hygiene, how to choose the right hand rub. So the reason I'm talking about hand hygiene is because hand hygiene is the primary measure which has been proven to be effective in prevention of healthcare associated infections as well as spread of antimicrobial resistance. So first international guidelines came in around 2009, and we know that contaminated hands are the commonest route of the transmission of these healthcare associated infections. So hand hygiene is actually the umbrella term for inclusion of hand wash as well as hand rub, which we'll be discussing and comparing later on, along with surgical hand hygiene. So a bit of microbiology behind the hand hygiene. So the skin flora is either the resident one and the transient one. So the resident flora is less likely to be associated with these healthcare associated infections, and it is the transient flora which actually colonizes the hand and is transferred from the healthcare workers to the patient. And this is what we must concentrate upon. So from social hand hygiene to clinical hand hygiene and finally to the surgical hand hygiene, it is the transient flora which we are focused upon, and gradually on and on the resident flora also is substantially reduced as we go on to the surgical hand hygiene. So it's not only the product, it is the identification of right moment of hand hygiene as per World Health Organization, and the correct technique of hand hygiene of hand washing within 40 to 60 seconds and of hand rub within 20 to 30 seconds. So it is the technique and the identification of moment which will make our hand hygiene effective. So when are we to concentrate only on hand wash and not hand rub? So we have to do exclusive hand wash when our hands are visibly soiled, if there is exposure to Clostridioides difficile, to infectious diarrhea or during norovirus outbreaks, or if there is exposure to Bacillus anthracis. Also, we know that with hand washing with soap, it is better for enteric and respiratory viral reduction than ethanol-based hand disinfectants. So, just to compare hand washing with hand rub, hand rubs, they fare better because of ease of use, accessibility, short time required, and effectiveness in killing these communicable pathogens, while the recommendations for hand wash we have already discussed. So to select an appropriate product, the product must contain an isopropyl alcohol, ethanol, or a combination of both in concentration between 65 to 95%. It may contain an antimicrobial or non-antimicrobial soap for all routine hand hygiene. For surgical antisepsis, there's again alcoholic-based hand rub, 0.5 to 1% of chlorhexidine gluconate for persistent activity, while 2 to 4% chlorhexidine gluconate for maximum persistent activity. So to select an effective hand rub, first that product should have the efficacy for decontamination of hands and should be efficacious in clinical use, and it should comply with the current standards, and it is our awareness regarding these standards and certifications of the product which is vital for selection of an effective hand rub. So just a moment regarding the chlorhexidine. Chlorhexidine itself is a cationic biguanide. It's available both as a solution and as a scrubbing agent, and it has a very broad spectrum of antibacterial activity in which gram-positive coverage is better than gram-negative. However, it has some limitations of activities, is pH dependent. It cannot, cleaning is required because activity is reduced in presence of organic matter. So, main thing is that on the basis of previous RCTs and studies, we know that alcoholic-based preparations are more effective as a hand hygiene agent. So again, since we have already, it is known that alcohols, they are strongest and fastest activity against a wide spectrum of pathogenic, both bacteria, fungi. They have low toxicity and mode of application is simple. Some of the products have sporicidal effect as well as virucidal effect, like the Zuagard CHI hand rub. So the European guidelines are some of the most stringent ones, that is mainly sporicidal, bactericidal, mycobactericidal, virucidal, fungicidal, yeasticidal, and even hand hygiene and surgical hand disinfection. So this product has a standard 70% ethanol with 2.5% of chlorhexidine gluconate, containing all the European certifications. So best practice for implementing this is audits, which have to be regularly feedbacks to the healthcare workers, and local programs of education, social marketing, audit and feedback should be there to consolidate the same. Single interventions will have limited and short-term influence. Reminder, feedback, accessibility, and multifaceted approach will consolidate these hand hygiene protocols. So to summarize, hand hygiene is the single most effective measure to prevent healthcare associated infections. I'll reiterate again, it's not only the product, it's the identification of the right moment and the right technique of hand hygiene which is going to make it effective. Standard is 70%, 65 to 95% ethanol with chlorhexidine, which we have already discussed. One thing I wanted to discuss, that with repeated use, the hands may be dry, so incorporation of emollients like glycerol and lanostrol, they are better tolerated with fewer these adverse skin events. And how to choose is, so validation of this product as based on WHO, CDC or European guidelines with certification is important prior to its clinical use. I thank you all for the patient listening. Thank you.
Thank you so much, Dr. ManoDeep. I think the message is very clear. The right hand rub at the right time in the right way. Thank you so much. Let's move on to the next topic. Let me invite Dr. Khemariya. He is a clinical specialist with Elsevier, and he is not only a doctor but also an MBA, and is working on AI, and that also on generative AI. What we need to listen from him, his view about ensuring responsible deployment of generative AI.
So good afternoon, everyone. Thanks to the speakers and chair for allowing me the opportunity. And I know we are a bit behind the schedule, but happily sacrifice some of my time to listen to more anecdotes from Dr. Gangadhar, our teacher. So it was great. Can you sort of switch the slides, please? So in the meantime, while the slides come up, I'll just introduce the whole concept of generative AI and ethical deployment. AI, as Kalyan also mentioned, is at the forefront of everything. And just put it, yeah, thank you. So my topic is ethical deployment of generative AI. And from the representative image, you can see that there is a doctor who's consulting a patient with an iPad, which sort of is like what we are trying to suggest. The doctor is using the iPad and not the patient. So it's always the technology is for the clinician to make use of. So what we will sort of discuss and learn by the end of my session is that how generative AI is impacting healthcare, what kind of application there are for generative AI, what kind of ethical deployment strategies can be utilized, what are the common pitfalls that an organization can encounter while using generative AI, and then we'll try and learn some of the pillars, how we can efficiently manage those pitfalls. So AI is not a new thing. Dr. Alan Turing, famous from the Imitation Game, in the 1950 paper, did describe or did ask the profound question, can machines think? And then Arthur Samuels developed some sort of a machine learning algorithm to play a game of checkers, and then they coined the term machine learning. A lot of different eruptions, evolutions happened over time. But then 30th of November 2022 is the date marked in history when GPT came to public consciousness. Everyone discovered that there can be a tool, there can be a chatbot where you ask question, it replies back, it gives you something interesting to sort of ponder upon. So that is the present milestone, historical milestone in the AI development, that is 30th November when GPT came out. The difference essentially being that AI is where machine is asked to think like a human and solve problems, while generative AI is where you, on a pre-existing data, where the machine learns and creates text, image, music, videos, deepfakes, whatnot. And then it's not perfect because the image, those who can see well, and maybe afterwards you can zoom in, I asked the generative AI to create the definition of generative AI on a monitor, and it does have its own mistakes. I think a good look can see the kind of mistake it does. So it's not perfect. Potential applications, some of the very innovative organizations like the one Kalyan represents are working on a lot of different use cases. The predictive modeling ones, the kind of where imaging is being used to create better results. But I'm going to focus on two parts. One is the personalized treatment one, and one is the clinical decision support, because these are the ones which are heavily influenced or have a very good future with generative AI. So just humor me for a minute. Here is a generative AI. You're trying to ask a question: what is the latest in epilepsy management? What it does, it looks into the query, it breaks it down into various kinds of terms, then it looks at various kinds of resources that may have answer to this question, and then through the capabilities of large language model, it creates a human-like answer to the question. Again, you can follow up that question with asking another question, that what if the patient is a pregnant female? So then it again has to dwell into literature, dwell into journals, dwell into books, and then find out an appropriate response to that. This is how the generative AI system works. It converses with you, takes into account what you have asked previously, and then generates a response accordingly. Now, before we go on to the further implications of generative AI, let's see what pitfalls are there to be avoided. The first and foremost is the black box phenomena. Black box certainly means that you do not know how the answers are getting generated, where the answers are coming from. So some of the organizations like ours, which has through history done what is considered the scientific good, which means that promoting peer review content, we have always felt that the black box does not serve well in the healthcare industry. You have to know that what kind of studies, what kind of research supports any kind of interpretation. So removing the black box is important. The other part is the administrative pushback is always there, because like any other technology, it requires you to sort of modify your ways. It requires you to change your approach towards patients. There is always the phenomena of, or the danger of, letting the generative AI do everything alone. So the lack of oversight is a definite pitfall. There always has to be someone looking after it. That's why I'm saying that the clinician in the loop should always be there. Then there is the twin side of it, where you try and make a hurried implementation. You try and find out how best you can utilize AI, and then you look at ROI from that point of view, that from tomorrow I get to get more efficient, I get to save money on some other kind of processes. So that's not the right approach. It takes time to get established. It takes time for your clinician teams to get understanding of how this can best help them save time and save cost. The evolving role of a clinician is also very important, that it's not there to replace clinician. It is a digital second opinion for the clinician, not for the patient. It is for the clinician. The clinician remains a touch point for the patient. They have to do the clinical validation. They have to do some kind of overriding protocols as and when required. The system also learns. They have to make sure the edge case scenarios where socioeconomic factors and other kind of self-harm scenarios where a generative AI cannot supposedly take a call. Like Dr. Gangadhar was explaining some of the anecdotes, where a human factor decides why the driver was going through what he was going through. That only a human can understand. So those kind of edge case scenarios, clinicians are always required. There is an interdepartmental coordination that is required to create the best use of any kind of AI. Now, these are the pillars. So first and foremost comes transparency, which means that rather than a black box, there should be a glass box. Wherever and from whatever sources the output is coming, we should know what is going behind from those sources. What is the fundamental basis of that information? That is very important. Same is with accountability, that someone has to be accountable for the final answers. There is an important phenomena which is called clinician in the loop. I think Kalyan also mentioned it, which means that internally and externally from both sides, clinicians always take charge. Wherever you feel the generative AI is not given a response which is up to date or which has some lacuna which can be better, there is always an option of feedback. And then from our side, the teams look at that response and do make those kind of changes. So those are required. And then there is always the phenomena of data privacy that the DPDP Act looks at. You have to make sure that you do not put in any kind of information that the patient can be harmed through. So these The continuous improvement part is very important. Any technology gets outdated very often, so there has to be continuous improvement. There has to be coordination between teams. Again, I tried the same thing with generative AI, and you can see it's not perfect. So that's what I'm saying, that if you look at generative AI as something which can replace you in some sort of a context, it's very difficult. It is not that, it is not that there yet. So in conclusion, generative AI is here to stay. It is coming. Second is that it is always, it is a very good digital second helping hand. It's not replacing anyone. There is always a need for the clinician to remain oversight of what is going to be done with it. Continuous improvement is the key. We have to make sure that continuously it gets updated. The kind of sources from where data is coming also needs to be more and more robust in terms of their nature. The guidelines, the consensus have to be more and more data driven. That's where the whole process can become very smooth, and the organization can make use of generative AI to sort of have more efficiency and more cost. Before I go off, one plugin from Elsevier. We have generative AI. We are at booth number 29. Clinical Key AI is a generative AI conversational platform which is powered through the content that is derived from books, journals, drug monographs, all kinds of verified resources. It converses you in a manner another clinician would. It tries to help you give insights into any kind of patient scenarios. It does give you that opportunity to create a kind of a history of a patient with various kinds of parameters coming in, various kinds of responses coming in. So it's something very fascinating for a clinician to do. Please do try out. We are at 29 number stall. It's at the low ground floor. Thanks a lot.
Thank you so much, Arun. So it was really a potpourri where we could listen to different topics and different ideas. Before I end this session, which was very beautiful to listen, let me ask Dr. Thuppil if he has to give some final comments.
Thank you very much. It was a wonderful feast. First, we heard keynote speaker telling us how to prepare good professionals for patient safety, patient care. At the same time, following that, we had experts who have come out with how to achieve with the technology. It's a fantastic combination of two things. Let us give a big hand to all of them. Thank you very much. Thank you, sir. Thank you. Thank you. Maybe at lunchtime you can interact with them and get your inquisitiveness, other clarifications from them.